as I recall, in the previous 6 weeks, there was no harm. So I guess I would...
So you look at it after the fact, and if the patient's still alive, then the doctor did a good job? Is that how you analyze it?
Well, you ask if he did harm to the patient.
No, I said, do you think he violated that oath? The oath being to do no harm.
I think he was providing a service to Mr. Jackson, which he had requested, in fact insisted on.
He provided a service. Correct? That was your word.
I said he provided medical care. Let's choose that as a better word than a service.
A better word than the one you used?
Well, it's a more appropriate choice of words, yes.
He was offered money to provide Propofol on a nightly basis, correct? Based on Conrad Murray's own interview with the police.
It's my understanding that he wasn't paid any money.
I didn't ask you that, did I? You have to be very closely attentive to my questions, okay? Please, Dr. White.
I will try, thank you.
Conrad Murray was offered money to provide Michael Jackson Propofol on a nearly nightly basis, per Conrad Murray's own statement to the police, correct?
I believe that may be correct, yes.
Okay. He was offered money to provide a service, the provision of Propofol, correct?
My understanding is he was offered money to be Michael Jackson's private physician and to be essentially, to have Michael Jackson as a sole patient.
Who's the final decision maker when it comes to making medical judgments in the doctor-patient relationship? Is it the patient or the doctor?
I think it's a shared responsibility.
Who's the final decision maker? If there's a conflict in, say the patient requests something that the doctor thinks would be harmful and is not medically indicated, is the doctor supposed to just do whatever the patient says?
Well, the physician always has the option to walk away from the patient. That's correct.
And so you, Dr. White, if you were asked to provide inappropriate medical care that you thought was harmful to the patient, and the patient insisted upon it, would you walk away?
I would never administer what I consider to be inappropriate medical care to any patient.
Okay, so is that answer yes, you would walk away if they insisted upon it?
Yes.
Thank you. Now, why is there a need for the continuous observation of individuals when they're sedated or anesthetized by Propofol?
Well, I think a major reason is if you're providing sedation, it's very easy, as we've discussed, to go from one level of sedation to another, either deeper sedation, closer to anesthesia, or lighter sedation. You can also have a situation where the effects are wearing off, and you may have a patient who's wide awake because Propofol has a very short duration of effect when you turn it off.
And for that reason, just what you refer to as a continuum of sedation, that's one of the reasons why you need to have constant monitoring of the patient.
When you're administering an infusion or repeated bolus injections, yes, that's correct.
Was it your testimony that if you inject someone, let's say with just 25 milligrams of Propofol, is it okay to then just walk out of the room and leave that person alone without any monitoring equipment?
My testimony is that giving a 25 milligram dose of Propofol will have minimal effects, lasting less than 15 minutes. So if a patient is observed for 20 to 30 minutes after a single dose, I see no reason why one cannot leave the bedside. As I mentioned, there are studies giving small doses for pre-medication before patients leave
And those studies, to be fair and accurate, you don't look at just the dose, you look at the effect on the patient, correct? Because the effect varies from patient to patient.
Absolutely correct.
Okay. So when you keep saying the dose, you have to also look at the effect. Would you agree?
Yes, and that's why I stated, sir, that you monitor the patient for at least 15 minutes after even a small dose, because this patient, given patient, may have an exaggerated response.
And then after 15 minutes, it's okay to walk out of the room and leave them on their own. Is that your testimony?
I'm saying that if I give a small dose of Propofol, that is a minimal sedating dose, 0.4 milligrams per kilogram, and I observe the patient and saw no untoward effect for 15 to 30 minutes is what I said. I said a minimum of 15 minutes, but ideally observe the patient for a half hour. I would see no problem in leaving the patient's bedside.
And that would be in a clinical setting? Medical hospital, office suite, something of that nature, correct?
That's the only setting in which I've given the drug, so yes.
But even in that setting, it's your testimony that you would inject a patient. I want you to assume they're not hooked up to any monitoring equipment whatsoever. There's no personnel in the room. You would inject them with 25 milligrams of Propofol, watch them for 30 minutes, and as they continue to sleep, you would leave them alone without any monitoring equipment or people on hand? Is that what you would do?
In a hospital setting, as we discussed earlier, typically they have an EKG running. They typically have a pulse oximeter on a finger, so I wouldn't characterize it as no monitoring. Having a pulse oximeter in place represents monitoring equipment. So,
well, if you're in the room, if you're out of the room and it doesn't have an alarm, it really doesn't represent anything, does it?
Well, it depends where you can observe. But I think that
if you can't see it and you're out of the room, a pulse oximeter without an alarm means absolutely nothing. Wouldn't you agree?
I don't agree that it means nothing.
What value does it have? If you're out of the room, you can't see it, and it has no audible alarm, and no one else is there, what value does a pulse oximeter have with no alarm?
Well, if you've observed the patient for a period of time and the pulse oximetry value, the saturation is stable, we know that Propofol in a 25 milligram dose will have effects that last maybe 5 minutes, maybe 7.5 minutes, and beyond that, virtually effects. So if you've observed them for 25 to 30 minutes, I think you can certainly move away from the bedside.
Okay, that wasn't my question. My question is, I'm asking about a pulse oximeter without an alarm. If you are not there to see it, to see the little tiny screen, and you're not there to hear it, it doesn't even have an alarm, what value does it serve?
Well,
in your absence, what value does it serve in your absence?
in your absence, it probably has little if any value.
None, correct?
Well, yeah, that's true.
Okay, it has no value, correct? If you're not in the room. Correct?
Correct, yeah.
Thank you. And 25 milligrams of Propofol, which you keep referencing, of course, assumes no other benzodiazepine on board, right?
Certainly no acutely administered benzodiazepines. If they've been administered hours before, they would probably have very little, if any, effect.
But they could have an effect.
They could have an effect dependent on the time interval between the administration of the last dose of the benzodiazepine and the small dose of Propofol.
Well, would that influence if you, that a patient had, I'm talking about you personally, if you knew a patient had lorazepam and midazolam on board, and you get 25 milligrams of Propofol, would you still just walk out of the room after observing them for 15 to 30 minutes, or would that be something that would raise your awareness to maybe pay a bit more attention?
I still feel that is adequate, in particular if the 25 milligrams of Propofol is administered over 3 to 5 minutes, very, very slowly. That represents a very slow dose that would not be expected to achieve a very high peak level. So you, again, my question was, would you, knowing that benzodiazepines were on board, and you administered 25 milligrams and the person had not woken in your 15 to 30 minutes of observation, would you be comfortable then leaving them alone without any monitoring equipment? Yes or no? said, it depends on the time interval between the last dose of midazolam and the slow bolus injection of propofol.
So would the fact that you knew benzodiazepines were on board in any amount alter your level of care?
I would certainly observe the patient carefully as I would even if it was just propofol alone.
But just for 30 minutes?
I think 30 minutes is certainly adequate for a slow 25 milligram bolus dose of propofol, even in a patient who has hours earlier received a small dose of midazolam or lorazepam. Yes.
And that would be the acceptable standard of care to administer midazolam and lorazepam and 25 milligrams of propofol, and with the patient not being hooked up to any monitoring whatsoever and no staff on board, it would be appropriate for you to walk out after 30 minutes. Is that your testimony?
Are you asking me about the standard of care or the standard practice?
I'm asking about the standard of care. Would you asking about you personally?
Well, the standard of care is the ultimate or most ideal standard of care, and obviously the standard of care would require monitoring, as I've suggested earlier.
Okay, so is that then that you would not leave that patient alone without any monitoring or any staff to make sure that they're safe? You would not do that? Is that correct?
I would observe the patient for a period of time. If this was an unusual case because the doctor was trying to achieve allow the patient to achieve a sleep state. So I think that once the patient was resting apparently comfortably and had been observed for a period of time such that the risk of either respiratory or cardiovascular adverse effects had passed, it's not unreasonable to leave it. It certainly is done in practice if you're giving a small dose on a one-time basis. It's quite different than the situation where you're giving an infusion or repeated doses. Then it would absolutely be unacceptable.
What if in your mind you had previously made statements that the patient likes to push the propofol themselves? Would that change your willingness to just simply walk out of the room and leave them alone with no monitoring?
It would certainly make me careful about allowing access to drugs.
Would you walk out of the room and leave them alone with no personnel and no monitoring if you were of the opinion they like to push propofol themselves? Would you walk out of the room in that situation, yes or no?
I would not leave the room.
Thank you. You can't justify Conrad Murray's failure to call 911 in the period of time, or in the waiting essentially 20 minutes to call 911, can you?
No, I cannot.
That's an extreme deviation from the standard of care, wouldn't you agree?
Again, these classifications are not familiar with me. I would say that given the fact that Dr. Murray is a cardiologist who is certified in advanced life support.
And assumes facts, not evidence.
Well, you may finish your answer.
Did he act like someone who was well-skilled in advanced cardiac life support? Did he act like that?
I was not present to make that assessment, sir.
You've taken all his statements as true in your assessment, correct?
I wouldn't necessarily say I've taken all his statements as true, no.
Do you think from your review of his statement to the police that he acted like someone who was well-skilled in advanced cardiac life support?
I think Dr. Murray, upon returning to Michael Jackson's bedside and finding him apparently in full cardiopulmonary arrest, probably reacted as many physicians would. He was probably anxious, and in those situations it's very stressful for anyone, even someone who is ACLS certified.
So that no well-skilled person trained in advanced cardiac life support?
I didn't say that, sir.
Well, I asked the question, and I'll ask it again. Did Conrad Murray, in your opinion, based on his statements to the police, act like someone well-skilled and well-trained in advanced cardiac life support?
I can't make that assessment. I would have done things differently in terms of calling for help and in terms of calling 911.
What would you have done?
Immediately, I would have called for help, although I understand this was sort of an isolated area, and it was
Isolated area?
of the house. Yes, I understand. It was a special suite of rooms on.
It was a bedroom upstairs.
Yeah, but
Okay. What would you have done? That's my question. What would you have done? You called for help.
to call for help, I would have assessed the patient, initiated cardiopulmonary resuscitation immediately.
And after making an assessment and starting cardiopulmonary resuscitation, if you were in that situation and you knew you had no person on hand and none of resuscitation equipment, wouldn't you call 911?
Yes, I would call 911, but my understanding is that this was an unusual situation because this was a house that had a secure perimeter and had no phones in the house. So it's a typical situation where you can call 911 and have immediate access to the premises.
I would certainly agree this was an unusual situation, but Conrad Murray had a cell phone in his hand, his own statement, and used it to call Michael Muir Williams. Are you saying he was not capable of pushing 911, maybe putting the phone down on speakerphone and continue the cardiopulmonary resuscitation?
It's my understanding that, number one,
I'm asking your opinion.
okay, my opinion,
Now, what you would do, there was a cell phone. Conrad Murray used it to call Williams. If you were in that situation, you come on the patient, and he's in full cardiopulmonary arrest, and you resuscitate the patient, and you start resuscitative efforts, and you've called for help, wouldn't you use that cell phone to call 911 as quickly as possible?
yes, but in calling 911, you need know the address. You would need to be able to ensure they could access the premises. And my understanding is
So is it your testimony because there was a gate around the house that excuses Conrad Murray not calling 911? Is that your testimony? Because you've mentioned this gate a couple times now.
no, it doesn't. It doesn't at all.
Okay, then we can set aside the gate, right? Because that's no bearing on Conrad Murray's need to call 911 as soon as possible, right?
Well, I think that's the reason we called the security individual, Michael Muir, to inform him that he needed urgency medical assistance.
Okay. And you realize when you had Michael Muir Williams, you didn't tell Michael Muir Williams to summon emergency medical assistance. You do realize that, do you?
If that's what you're saying, yes.
Wouldn't you agree it's much quicker to call 911 than to call someone's personal cell phone number, have it ring through to voicemail, and then leave a message on that voicemail? Would you think it would be much quicker to simply call 911 and even put the phone on speakerphone and continue with resuscitation? Would you agree with that?
Well, you can have people on speed dial and call them even faster than 911, so I think certainly 911 is easy to dial. You're absolutely right.
So there's no justification for what Conrad did in failing to immediately call 911, is there?
As I said earlier, I think he should have called 911 sooner. I do not, however, think it would have made any difference in the outcome of this case.
If you personally came upon Michael Jackson in that state where a pulse was felt and you assessed the patient and you started resuscitative efforts, how long would it take you to decide setting in a bedroom in a home that you needed to call 911?
Are you saying if I felt a pulse?
Well, Conrad said he felt a pulse, yes, so that's what I'm saying.
He said he felt a thready pulse.
He said he checked the pulse oximeter and it read 122, and then he felt the femoral pulse and he felt a thready pulse, correct? In that situation, if you came upon those facts, how long would it take you to decide that you should call 911?
Well, again, if I came upon that situation and I was ACLS certified and cardiologist, I would immediately start resuscitating the patient and call 911 shortly thereafter.
But shortly thereafter?
3 to 5 minutes, I would guess, if you ask me for a number.
In this type of situation where paramedics are eventually called and they arrive on the scene, doesn't a doctor have a moral and ethical obligation to reveal all medicines to that responding emergency personnel that have been given to the patient that could affect the treatment?
I think in general we try to recount all the events, but in an emergency situation, as happens in hospital environments as well, it's often difficult to recall details in that kind of situation.
Is it your testimony that the failure to mention Propofol to the paramedics with an inability to recall details? Is that your testimony, Dr. White?
Well, I'm just saying details can be overlooked. I'm not saying it's appropriate, but I don't think it was done in a devious fashion.
You think, so I just want to be clear, you think it's just a detail that was overlooked when Conrad Murray failed to advise paramedics he had been administering Propofol? Is that your testimony? Was a detail that was overlooked?
I don't think I used those words. Propofol, a small dose of Propofol, could not be reversed. It's not like benzodiazepines.
Do you understand my question to ask you if Propofol could be reversed? Is that how you construed my question? Is that how you construed my question?
No.
Okay, then please listen to the question and please try to answer my question. Is it your testimony that Conrad Murray's failure to inform the paramedics that he had administered Propofol was simply a detail that had been overlooked? Is that your testimony?
I think it was something that he overlooked.
Okay.
Yes.
Having time to ponder it and think about it and ride along in the paramedic's vehicle while Michael Jackson lay on a gurney and then arriving at UCLA, was it still then another detail that he overlooked at UCLA when the emergency room doctor specifically asked him what had taken place? Is that your testimony, that again was a detail that was overlooked?
Well, it was obviously overlooked. He didn't.
Well, not obviously. It could also be a lie, correct? Correct? That's another option.
If you say so, I guess, yeah.
That's another option, correct?
It's an option, yes.
Thank you. Now, you said in your report, Dr. White, that in your opinion this was, as you said here today, cardiac arrest, and you characterized it as that the central nervous system depressing effects of this combination of medicines can produce significant ventilatory depressing effects as upper airway obstruction, parentheses, due to relaxation of the pharyngeal picture, correct?
You mentioned a report. I didn't actually write a report. The letter can...
Please ever give whatever you want to call it. This 3.5-page document was the only thing I ever received from you. You want to call this a letter or a report?
It was a letter.
Okay, this is the only thing I have. So this was what documents your findings, correct?
No, not at all.
Is there some other information, reports you've given to the defense that you didn't provide to me?
Not in writing, no. But I've certainly conveyed my evaluation of materials to the counsel over the phone and then in person.
What do you want to refer to this as, a letter or a report?
I think it's a letter.
Containing findings at the time regarding this case, correct?
It contains some preliminary thoughts on this case, yes.
And this is the only document you've ever provided, is it? It contains preliminary thoughts.
Correct.
And in this letter containing your preliminary thoughts, you state that it was likely acute cardiopulmonary arrest where the central nervous system depressing effects of this combination of medications could produce significant ventilatory depressing effects as well as upper airway obstruction, correct?
I don't have the document before me, but it sounds like something I may have written, yes.
Would you agree that the risk of adverse drug reactions increases when combinations of sedative and analgesic drugs are administered?
When combinations of sedative and analgesic drugs are administered, yes, I would.
And that the potential for compromising the respiratory system results from depression of esophageal and laryngeal reflexes, upper airway obstruction, and depression of central hypercarbic and hypoxic ventilator responses. Would you agree with that statement?
Correct.
And although benzodiazepines may be used as an appropriate, procedure of sedation or anesthesia, you're well aware of the contributory effect that these drugs can have, and that it increases potentially the dangers of what is being administered. Would you agree with that?
You were earlier referring to sedative analgesic. That's very different than just talking about sedatives. I'm not aware of studies that have looked at the effects of prior benzodiazepine administration on ventilatory response to Propofol, for example.
Is it your testimony that the prior administration of, for example, lorazepam and midazolam, is it your testimony that does not increase the risk in any way to respiratory failure?
As I stated earlier, it depends on the time interval following their administration.
So there is a risk, but it depends on other factors. But there is a risk, correct?
There's potentially a risk, but it's only theoretical, and it depends on, or it assumes that that time interval is fairly short and the blood levels of the benzodiazepine are high.
You said it's a theoretical risk, but you opined on Friday that because, in your opinion, Michael Jackson swallowed lorazepam pills and then quickly injected Propofol, that he essentially killed himself, correct?
I suggested that one of the possibilities is that there was a high concentration of lorazepam, which I believe was measured at autopsy, and if one then administered very rapidly Propofol, you could achieve a cardiorespiratory arrest. Certainly an arrhythmia could occur, and this could result in very rapid demise of a patient.
Who's responsible for bringing Propofol into Michael Jackson's home, in your opinion?
Well, Conrad Murray certainly purchased Propofol, but I understand Mr. Jackson had his own supply as well.
Really?
Correct.
Where is that in the police interview by Conrad Murray?
Well, I had heard that...
Objection.
Okay.
Non-responsive. Where is that in the police interview?
Sustained. The last partial answer stricken.
You keep throwing out these kind of rehearsed lines, I think. My question is, where is that?
Just a moment, please.
Objection, this argument.
Sustained.
Please.
Ask a proper question. Thank you.
Where in Conrad Murray's statement to the police is that reflected?
I don't have the report in front of me. I reviewed it in February, and as I indicated, I've had two
Objection, motion to strike. Would the court admonish the witness?
The objection is sustained. the answer stricken, disregard, please. May I ask a favor, ladies and gentlemen, if you could just leave us for a few moments, please? Remember the admonishments. Don't get too comfy. I'm just going to ask that you go into the jury. Thank you.
Nice. Nice.